Hi, everyone. My name is Gaylen. I'm a graduate student in the clinical psychology program at UW, and I'm going to be talking to you today about a project that I've been working on that seeks to apply machine learning approaches to improve precision mental health research by taking advantage of high throughput computing. Um, so I'd like us to start by thinking about how we traditionally assign treatments. When a patient walks into their doctor's office, or right now maybe joins their Zoom room and describes their presenting problem, the doctor is going to select a treatment for them from a wide variety of available options. And likely an important factor in that decision will be how effective the treatment is. So, for example, if there's a treatment that works for 75% of people with those symptoms, the doctor is more likely to choose that option than a treatment that only works for 25% of people. But what if the patient is this person? This patient wouldn't have improved with the more effective treatment, but the less effective treatment would have worked for them. And this illustrates a problem with how we assign treatments, in that what works best at a population level does not necessarily work best for a given patient. And this is where precision mental health comes in. Precision mental health is the application of the precision medicine paradigm to mental health and psychological conditions. And its goal is to take advantage of individual difference characteristics to select the treatment that's predicted to work best for a given patient. And when it's successful, precision mental health would be expected to increase the likelihood of treatment success within an individual because each person receives the treatment that's predicted to work best for them, as well as to improve treatment effectiveness rates across the population because each treatment is only being used with the subset of patients expected to respond most positively. And the idea of precision mental health has been around for a while, but there hasn't been much progress made. And one of the reasons for this is that traditional analytic techniques have limited us to considering only one or a small handful of individual difference predictors simultaneously, which means we can't capture the complexity of clinical phenomena like treatment response. Fortunately, the advent of contemporary analytic techniques like machine learning has provided a new path forward for building these treatment selection algorithms. Machine learning models can handle hundreds or even thousands of predictors simultaneously, which means that they can capture the complexity of both patients and the associated clinical outcomes that we're trying to predict. Additionally, machine learning makes use of methods that prioritize out-of-sample prediction by fitting and evaluating models in separate data. And this means that we can know how well our models perform in new data, in other words, with new patients. And this is really critical because it aligns better with our clinical science and application goals. So in my project, in each model, we're trying to predict an outcome, which is whether the treatment was successful or not 6 months after initiating that treatment. And then to do that prediction, we use each patient's treatment condition, so which medication the patient was assigned, and approximately 400 individual difference characteristics that are assessed at baseline, so before they start their treatment. And these characteristics include things like medical history, demographic variables, and symptom severity for whatever they're seeking treatment for. The reason that CHTC is so important to this project is that fitting machine learning models involves using rigorous resampling techniques like cross-validation. So for those of you who are not familiar, the general idea underlying cross-validation is that one portion of your data is used to fit models, and then that model is evaluated in new data that the model has never seen. So here you see one split, but we use a specific method that repeats that splitting procedure such that we have hundreds of independent estimates of how our model will perform in new data, which gives us a more robust and more precise estimate of model performance. And again, this method prioritizes how well the model performs in new data rather than in data used for model development. So in other words, how well the model generalizes. And that's really critical, again, for those clinical science application goals. Within each cross-validation iteration, we're fitting not just one or a small handful of models, but many, many model configurations. And we consider many different statistical algorithms that might capture different types of predictive relationships. Each of those statistical algorithms has associated characteristics that can also vary, such as hyperparameters, also called tuning parameters, and those help control how the algorithm runs. And then these algorithm characteristics are crossed with other characteristics related to the features or predictors in the model. So will we include all predictors or only specific subsets? How will we derive or create engineered features from the raw predictors? Will we do anything to address the fact that our outcome is unbalanced, so it's not a 50-50 split about whether people are successful in treatment or not? As an example, let's say that I'm fitting a random forest algorithm. This algorithm requires me to tune 3 different associated hyperparameter values. And so I allow a few values for each for a total of 100 unique combinations. I'll also allow my models to use either item level or total scale level self-report data, since those are entirely overlapping. One could be completely recreated from the other. And this creates 200 different models to be fit. We also have to multiply this by the number of cross-validation iterations that we have. So conservatively, let's say we have 100 different splits of our data. That would mean that just for this scenario, we would have 20,000 models to fit. To maximize the parallel processing capacity of high throughput computing, we break our model fitting process down into small, single, independent jobs that can run on different cores or machines. Specifically, each job fits a single model configuration, so a single combination of algorithm, feature set, and hyperparameters in a single cross-validation iteration. These jobs are submitted to CHTC machines as well as to the Open Science Grid. And then once these jobs are run across these machines or across cores, we aggregate the results, so the out-of-sample performance for each model, and we aggregate that locally to select the model configuration that performed best across cross-validation iterations. Because we break our model fitting process down into so many small jobs, each model only takes a few minutes to run, although it's possible that some would take longer as models become more complex. And although each job is fast, this would take days running locally, even across a multi-core machine that could run jobs in parallel. Returning to our previous example with the 20,000 jobs and averaging about 2 minutes per job, this would take about 650 computing hours. In addition to needing to multiply this by the many intended scenarios like other statistical algorithms and feature set variations, it's also important to note that this is not a one-off process. There's testing, trial and error, and iteration as I learn more about how to improve model performance. Running jobs via high throughput computing and CHTC makes this testing and iteration possible, which ultimately will improve model performance because it allows me to try things out at low computing cost. In terms of the process of using CHTC and HTCondor so far, far and away the most valuable element of UW's high throughput computing is the CHTC support team. They're very helpful, very patient, and they've been instrumental in getting projects like this and other projects in our lab off the ground. They're also extremely helpful for troubleshooting errors. As someone who is coming from a more psychology focused background and has been sort of learning data science and programming along the way, it's difficult for me sometimes as I'm switching between platforms and systems to understand what's going on. And so they've been incredible with helping that. They also remain really conscious of best research and computing practices, which helps me and my colleagues feel confident that we're conducting rigorous data science. The clear documentation and walkthroughs available online are also critical, especially when I'm in a setup phase. I pretty much just keep the running in R tab of the CHTC website open. And then in my lab in particular, we have several projects that are using or have used CHTC services. And the uniformity of the CHTC process across projects means that we can all benefit from one another's experience and expertise. CHTC is critical for this kind of project to have impact. From a research and clinical standpoint, I believe that machine learning is necessary for precision mental health research and algorithm building to advance meaningfully. And this process requires the computing power that CHTC provides. It also allows me to maximize my own time, resources, and person power. Other than my mentor, I'm the only person working actively on this research project. So running jobs at CHTC is not only more efficient, but also frees up my own local computing capacity for code development and analysis, rather than me being essentially locked out of my own computer for days while fitting models. I'm also able to expand my research rather than having to worry about keeping my project and modeling process simple for computational reasons. I can freely add complexity knowing that I have the computing power to handle it. For example, I've recently been given access to genetic data collected from the participants in the data with which I've been working. And this may add hundreds of features to my models, which will drastically increase the runtime for each job. CHTC makes this feasible and indeed allowed me to get a seed grant from UW's Center for Human Genomics and Precision Medicine to add genetic features. I'm also currently writing a fellowship application to continue working on this project, and being able to cite CHTC makes that project entirely feasible with respect to computing resources, as well as the modeling and computing support from the CHTC team. Similar applications from our lab repeatedly get comments about how without these resources, they would view our projects as unfeasible. And so we're really lucky to have that resource. That is all I have. Thank you all so much for listening, and I'm happy to take any questions.